All right, doctor, let's dive right into this explainer on James McKeefrey's case. We're taking what has been presumed to be a terrifying terminal diagnosis and completely flipping it on its head. We're going to map out a highly detailed, systemic, mechanistic model instead. Now, James is 72, and honestly, the picture painted so far points very heavily toward Lewy body dementia. But as we unpack the data today, we're going to look at this through a completely different lens, a lens that asks a really important question. Are we misreading severe system noise as permanent structural decay?
Just look at this quote from the patient's advocate. It really hits the nail on the head and frames our entire approach. We need to shift the focus from this idea of irreversible brain decay to a compounded functional collapse across multiple systems. When we stop treating this as just a single organ disease, an entirely new, highly actionable picture emerges.
So here is our roadmap for today. We'll start with a complex clinical presentation, then map out the 4-ring architecture. Next, context reframing LBD symptoms, followed by distinguishing sleep and vision. Then we'll be assessing system reversibility, and finally, looking at the stabilization protocol. Let's get right to it.
Section 1. A complex clinical presentation, the baseline and the paradox. Let's ground ourselves in the baseline facts that we both agree on regarding James's deteriorating condition.
So, James is 72, and he's presenting with some undeniably alarming stuff. We're talking cognitive decline, severe brain fog, and syncope, fainting spells. He's got obvious Parkinsonian features too, like a shuffling gait and tremors. Add in these really complex sleep behaviors and a reported nighttime hallucination, and honestly, the presumed diagnosis of Lewy body dementia seems almost unavoidable. The observation points in that direction. These are very real, very scary symptoms. But we absolutely have to ask if they reach the correct conclusion when we place them in a broader physiological context.
Moving on to Section 2, the 4-ring architecture, mapping the self-reinforcing loops. Let's look at how these symptoms are actually being generated by examining the physiological layers that are currently in total chaos.
And it all really comes down to the number 4. James's condition operates across 4 distinct, highly interconnected regulatory rings. Think of it like a giant puzzle, where every single piece is constantly amplifying and scrambling the others in a self-reinforcing loop. Let's peel these layers back, starting from the outside in. Okay, starting from the outside, ring 4 is the medication layer, and this is our most immediately modifiable layer. James is carrying a hefty combined burden of propranolol, nortriptyline, clonazepam, and antihistamines. Put those together and they are driving severe autonomic suppression and literally destroying his sleep architecture. The propranolol is blunting his compensationary heart rate, which directly contributes to a syncope, while the nortriptyline is just piling on this anticholinergic cognitive slowing.
Now this massive medication burden feeds right into ring 3, the MCAS, or mast cell activation syndrome loop. We know his Ig levels are sky high. And what's really fascinating here is this metabolic subloop he's stuck in. His circadian rhythm is so dysregulated that it's impairing his glucose timing. This causes a neurobiologically driven craving for carbs, sugar in his tea, root beer, evening sweets. This is not just a guy with a bad diet. It's a struggling metabolic system crying for help. And that sugar intake, it triggers massive mast cell amplification and histamine release, which violently fragments his deep, slow-wave sleep.
Which cascades perfectly into ring 2, the regulatory core. That histamine-driven sleep fragmentation basically collapses his entire circadian rhythm and his autonomic stability. Because he's getting zero-quality sleep, his brain's glymphatic clearance fails. That causes neuroinflammation to spike, which just wrecks his autonomic regulation even more, disrupting his sleep further. It's a completely vicious, inescapable cycle. And finally, dead center, we reach ring 1, the core neurological findings. His EEG shows a 7 Hz posterior dominant rhythm and right temporal posterior focal slowing. Now, we know our neuroanatomy, right? The right hemisphere controls the left side of the body, so this documented right-sided slowing perfectly explains his left-sided physical symptoms. It's completely coherent. It's lateralized anatomy behaving exactly as you'd expect a system to behave under extreme duress. It doesn't automatically mean irreversible brain death.
Section 3. Context. Reframing LBD symptoms. Stripped context versus applied context. So, how on earth does this 4-ring architecture mimic Lewy body dementia so perfectly? Let's see what happens when we look at the data without context versus when we apply the full picture.
This is a brilliant illustration of the paradox. James scored a 23 out of 30 on his MoCA, and he lost 5 of those points entirely on word recall. Now, without context, failing word recall looks like permanent hippocampal brain damage. But let's apply the context. We know memory consolidation happens during slow-wave and REM sleep. James's sleep architecture has been utterly decimated by 3 autonomic medications and multiple sleep disorders. Trying to test his memory recall in this state is literally like trying to test a computer's hard drive while you're actively unplugging it from the wall. The deficit is exactly what you'd expect from a lack of sleep consolidation, not necessarily structural degeneration.
And we see the exact same illusion with his Parkinsonism. Without context, a shuffling gait and a tremor, that equals progressive LBD neurodegeneration, for sure. But applied context shows us a post-COVID dopaminergic injury. We know SARS-CoV-2 infects midbrain dopamine neurons via ACE2 receptors. When you compound that viral injury with a massive medication burden and right temporal functional slowing, you get a perfect Parkinsonian phenotype, all without needing fixed structural decay to explain it.
Section 4. Distinguishing sleep and vision. Artifacts, not hallucinations. Doctor, let's systematically dismantle the 2 biggest red flags that triggered the LBD alarm in the first place: his sleep behaviors and his visual hallucinations.
Distinguishing these sleep behaviors is absolutely vital. A classic hallmark of LBD is REM behavior disorder, or RBD, where patients physically act out their dreams. But James doesn't have RBD. He actually has a 46-year history of periodic limb movement disorder, or PLMD. This is a totally stable baseline finding that predates his cognitive decline by decades. It happens in non-REM sleep, and it's a stereotyped robotic movement, literally just elevating his elbow twice. It's not a narrative-driven response to a dream at all. And those recent night terrors? Actually, scratch that. They were directly induced by first-generation antihistamines from an allergist. Once the drug stopped, the terrors stopped.
Okay, so what about the visual hallucinations? He reported seeing a figure in his room at night one single time. Well, the very next week, an ophthalmologist confirmed a physical floater in his left eye. Think about it. Take a physical eye floater, process it through a functionally slowed right hemisphere in a pitch-black room while his blood pressure is dropping during a circadian trough. That's a perceptual artifact. It is a pure optical illusion born from a struggling system, entirely different from the complex, recurrent, fully formed hallucinations that define LBD.
Section 5. Assessing System Reversibility. The Modifiable Terrain. Doctor, this brings us to the most hopeful and actionable part of this whole explainer. If this is a regulatory failure, can we reverse it?
Yes, we can. By reframing this away from structural decay, we are suddenly looking at a highly modifiable terrain. Almost every single compounding factor here can be reversed or stabilized. The medication load? High reversibility. That's our most immediate target. Sleep quality, circadian anchoring, autonomic stability, and that vicious mast cell histamine loop, all of these have moderate to high reversibility through targeted protocols, pacing, and some careful medication reviews.
Which brings us to Section 6, the stabilization protocol, upstream first. We literally cannot accurately read the true neurological signal until we remove the noise. We have to work upstream first.
So here's where we start. Step 1, we need an immediate, supervised review and reduction of the medication load, specifically those anticholinergics and beta blockers. Step 2, get a proper baseline sleep architecture assessment. He needs a polysomnography to properly document the PLMD. Step 3, reduce his nighttime nervous system load with better screen timing and amber lighting. And Step 4, stabilize the MCAS loop using targeted H1 and H2 blockers to shut down the histamine spikes, keeping him awake.
Now, I know what you might be thinking. Why not just order a DAT scan and prove if it's Lewy body once and for all? Well, take a look at this. Even advanced diagnostic tests, like a DAT scan, won't give us clarity right now. A DAT scan confirms reduced dopaminergic signaling, sure, but it cannot distinguish between a dopamine neuron that was simply injured by COVID-19 versus one dying from primary neurodegeneration. It just won't give us the answer while his regulatory system remains in such modifiable chaos.
So, Doctor, I leave you with this absolutely crucial, provocative question to consider. Can we truly diagnose irreversible structural neurodegeneration while James's regulatory system is in modifiable chaos? Shouldn't we stabilize the terrain, peel back the layers of these 4 interacting rings, and quiet the system noise before we officially declare the structure broken?